Hey, well, we're really privileged to be joined by Dr. Ruth Elwood Martin today. She has a great deal of experience dealing with prisoners and the issues that they face. Ruth, maybe you could tell us a little bit about your experience actually being a doctor for prisoners in the federal system, and tell us a little bit about what you're doing now at the University of British Columbia. That would be great.
So thank you, Catherine, and thank you for inviting me. And so, yeah, I started to practice as a family physician in the community in Vancouver in 1983. That's a very long time ago. And then in 1994, I started to work part-time as a prison physician in the clinics of, actually it was Burnaby Correctional Centre for Women, which was a federal provincial women's facility. And then when in 2004, when that facility closed, I then moved into the provincial system, working mostly in the women's facilities, but also in the men's facilities. So a total of about 16 years working as a prison physician. And, you know, as I started to work in the prison clinics, I was impressed by how much health disparity I was seeing compared to my community practice. And that really inspired me to sort of look at the international publications to find out how best practices can be done in terms of helping people with their medical and mental health issues in prison. And that prompted me at the University of British Columbia. So as a clinical faculty there, I was involved in teaching medical students and residents. But it prompted me then to help establish the Collaborating Centre for Prison Health and Education, which formed in 2006. As a network of people working together. So it wasn't just academic faculty. We invited nonprofit organizations such as John Howard and correctional organizations like BC Corrections Branch and Corrections Service Canada, so that we could actually work in collaboration to try and seek to improve the health and well-being of people who are incarcerated and their families. And so we had the objectives to do research, service, advocacy, teaching. And part of that then evolved into engaging men and women with incarceration experience as advisors. So as key kind of integral components to a lot of the activities that we were doing, because I also was involved in participatory health research, where you're actually asking the person who's afflicted by the conditions to say, tell us how we should look at this and tell us what the important questions are. So, so since 2006, and we've been involved at CCPHE, Collaborating Centre for Prison Health and Education, and yeah, so it's been a long journey of working on these issues.
I think the collaboration has actually paid off, because we are getting some pretty good definitions of meaningful human contact from, for example, the provincial corrections authorities in BC that we don't find anywhere else. So it's good that you've had that collaboration and some measure of comfort that must be gained by being willing to share things with others. That's really good for correctional authorities. It's great. In your practice, did you get involved, or did you see many prisoners who had been put in isolation? So this would be 22 hours a day in the cell or more without meaningful human contact?
Well, you know, when I was working as a family physician in the medical clinics, I started off sort of just thinking that, you know, corrections do their thing in terms of discipline, and I work in the clinic and do my thing in terms of meeting health needs. And so I might be called to see a patient that was in segregation, or they might be brought to the medical clinic. But I didn't kind of question the practice. I just thought, this is what happens in a prison. And so it wasn't until I actually was visiting the UK, and I went to a women's prison in Manchester to actually primarily to look at the mother-child units, because I was really interested in mother-child units, and they had quite a thriving mother-child unit. While I was doing the tour of that facility, they said, oh, would you like to see our special unit that we've opened? I think it was about 3 years at that time. And their story was that they found that in solitary confinement, too many people were committing suicide. There was a very high rate of suicide. And so what they had done in that prison is they collaborated with the community, with health organizations in the community and mental health organizations. And they'd actually formed a unit that people who needed extra help would go to, but they actually resolved never to have that person alone. So they weren't going to be in isolation. They were actually going for extra help mental health supports, counseling, group therapy, whatever. And so
Wow.
when I went into that unit, it was like a hub of activity. I couldn't believe it. Everybody was in civilian clothes and people were doing group sessions, and I was just blown away. And I kind of went, oh my goodness, actually segregation or isolation is not modern practice. Like what we're doing so that was my first sort of inkling that actually, oh my goodness, what we're doing is actually could be done differently and is being done in different countries. And Catherine, I'm sure as you've traveled, you've seen that, you know, we hear about instances in other countries where, no, this is not common practice. And actually there are different ways of doing things. So yeah, so then I became much more aware of this issue. And, you know, started researching it and getting involved in advocating for different ways of doing things.
Yeah, it looks as though the body of research into solitary confinement and its impacts have really expanded over time, and fairly recently, a lot of the researchers are really seeing some of the negative consequences of that kind of isolation, which is really good. But it's, I mean, can you expand a little bit on what the implications are of that kind of sensory deprivation or isolation?
Yes. So, you know, as you can imagine, it's actually difficult to do research on this in today's society. I mean, we can't do a randomized controlled trial. That would be totally unethical. So some of the documentation of those kind of symptoms are really in quite old publications. So I think there's a classic one in Denmark in 1986 that documented Danish detainees in isolation. And so even though the United Nations says that 15 days of isolation is considered torture, and that's the kind of, you know, international standard, that it shouldn't be longer than 15 days, we know that even after a few days, people are actually going to start exhibiting symptoms. And you know, it's things like, so I'm sort of looking at my notes here, but problems of concentration, restlessness, failure of memory, sleeping problems, impaired sense of time, and a difficulty with day and night rhythms. And then after, you know, longer periods, then it actually progresses into things with difficulty with memory and concentration and fatigue, incredible emotional lability, fits of rage, hallucinations, and then this common belief that I must be losing it, I must be going mad. So the publications and the studies that are described say that actually any period of isolation can exacerbate existing mental health symptoms or mental health issues. It can bring on the onset of mental health issues, and also obviously physical symptoms and physical illnesses can be worsened and can bring on, depending on how long you're in. So physical conditions such as diabetes or hypertension or heart disease or obesity, all of those are exacerbated. And so, you know, when I was in family practice, I'm retired now, but in family practice, I'd see patients, and it was, you've got to get exercise, like 30 minutes exercise. And that's what we're supposed to do. That's what we're recommending the general public. Well, if you're in isolation in a cell, it's impossible for you to actually be healthy in that way. Yeah,
I think the statistics are pretty clear that if you're looking at where the suicides are taking place in the prisons, there's, you know, they're overly sampled in these isolated conditions. Like, it's very devastating for people. There
was a more recent study in New York that actually did demonstrate that correlation. So they looked at detainees in New York jails and showed, and it was a large sample size, and they were looking at linked databases, and they actually showed that there was a higher rate of self-harm, including lethal self-harm, suicide rates, in anybody who had previously had a time of solitary confinement or mental illness or under the age of 18. So it was very clear. And I think that New York, as a result, changed their practices so that they no longer put people in solitary confinement, and they try to route people with existing mental health conditions to a more clinical setting instead of putting them in cells.
I think that makes eminently good sense. I mean, when you look at some of the examples that have come to light in the Canadian context, like Ashley Smith and Eddie Snowshoes, I mean, it was pretty clear that these people were suffering, and yet not much was done to kind of relieve their suffering until ultimately they took their lives. You know, I mean, many of the people who don't take their lives have also suffered terribly in administrative segregation or solitary confinement. As you point out, it's probably much worse for people who have an underlying mental health condition, and then they're, you know, that whole what's real and what's not real sort of breaks down, and it's not good at all. One of the areas that we're looking at during this 15 days are different types of isolated confinement that actually meet the definition of solitary confinement. So the United Nations definition is 22 hours in the cell without meaningful human contact. And sometimes people are placed in those circumstances. Like we're seeing a lot with respect to COVID, that there will be quarantine that they're placed in, and there will be medical isolation. And oftentimes they're just basically put back in the conditions that we would call the whole solitary confinement, even though they're ill, which is, I think, is somewhat disturbing. We have an affidavit from one prisoner who was at Mission who contracted COVID-19, spent, I think it was 10 days in an intensive care unit in a local hospital, came back and was put into the most extreme isolation that he's ever experienced in his prison journey. And it was devastating, just devastating for him. I was wondering if you can think of any alternatives, like if you need to place someone in isolation or to ensure that they're not spreading a virus. It strikes me that there must be more humane ways of being able to do that than to put them in that kind of a setting. Can you think of any ways?
You know, I guess it comes back to the fact that in our incarcerated population, we have a higher prevalence, we know this, of people with mental conditions. And we also have a very high prevalence of people who have been traumatized, either in childhood or as adults. And so I think in terms of, you know, considering any individual, you have to assume, I mean, it's like universal precautions. You have to assume that universally they will have been traumatized at some point. So let's look at ways that we can provide a trauma-informed approach to caring for this individual. And so, you know, that kind of starts with a person-centered approach. So I would think that one of the most humane ways is to actually ask that individual, you know, how would you like to engage in this care plan? You've been diagnosed with COVID, we need to put you in isolation. What are your suggestions? How do we engage you in this in a person-centered way that we're respectful of your health and your background? But my experience is that when you actually listen to people about their own health concerns, they actually have a lot of input and a lot of wisdom. And, you know, obviously that takes time. It takes a change in mindset in terms of the correctional officers becoming caregivers in some way, or engaging the healthcare providers or the community organizations in helping to actually describe what that's going to look like in practice.
Yeah, I think that's very good. I mean, if the person that we know who had been placed in isolation like that after he was so ill was given that opportunity, I'm sure one of the things that he found most devastating was being alienated from his spiritual supports and being alienated from his family, right? If there was some way just to improve links, whether it's even Zoom calls or some sort of technology, would have made a big difference.
Absolutely, absolutely. And, you know, in the terms of the sensory deprivation, that's what universally people are saying in segregation. It's that lack of human contact. So we need that meaningful contact with people. There's just so much more that could be done in an individualized approach to people's needs.
One of the forms of isolation that people find traumatizing is this dry celling experience. So this would be a perception that a person has ingested drugs or hidden drugs in their bodies, and they would be placed in this cell that doesn't have any access to water, where they will be forced to use the toilet in front of people. and then they would be looking for the expulsion of the drugs. And it's even for those who have swallowed drugs and are producing them, it's a traumatic experience. I think more so for people who are wrongfully placed in those kind of settings. And there's recently been a case where a woman was suspected of having hidden drugs in her vagina and was placed in this dry cell. And she was placed in there for 16 days. And it was a very traumatizing experience for her. And I'm just wondering if there's, any logical alternatives to dealing with the perception that drugs are being hidden in people than subjecting them to that.
Well, clearly that violates the United Nations rules for what should happen to prisoners. And I'm not familiar with this, so it seems there has to be alternative ways. I suppose it's trying to understand what the correctional authorities are trying to accomplish as a result. Is this they're trying to prevent drugs getting out into other populations or something? It's just,
I think so.
It just seems to be violating. So I'm not sure, but it clearly violates the intent of the Nelson Mandela rules about solitary confinement. So it clearly should not be happening.
The woman eventually consented to an internal examination. They found no drugs, right? But,
and even that I'd have difficulty with, because internal examinations shouldn't be done for that purpose.
Yeah.
So no healthcare provider should be asked to do an internal examination to see if there's drugs on board. That doesn't seem like an ethical practice.
Yeah, that's interesting. I think what you've suggested really makes sense in terms of actually involving those who are being isolated in what they need to keep whole during that period. There are a few people who are vulnerable in the prison population and are looking for more security, but being placed in these special ranges where they don't interact with others is very damaging to them. And it seems to me you should be able to have some population management strategies that will keep them safe without jeopardizing their mental and physical well-being.
So another aspect to this is actually having a different approach. So I'm thinking about the provinces that have transferred the administration of their healthcare from the Ministry of Public Safety and Solicitor General to the Ministry of Health. So in BC, that happened in October 2017. And the World Health Organization has recommended this should happen for years. And so we were delighted that this happened in BC. And so now we're looking at, not we, but generally, the academics in BC are looking at ways to try and evaluate the impact of that. And I've always felt that surely there would be then a better approach to helping people within the facility with their mental health conditions. And so the word is that I'm hearing that, so there has been an increased effort to not use solitary confinement for people in provincial BC corrections. And that has happened because there's been actually more consultations happening between the health care workers and the correctional officials in terms of education, in terms of trauma-informed practices, in terms of trying to move beyond this and to try to discuss alternative ways of handling this situation. So, I think part of it is education for correctional officers about trauma-informed approaches and education for wardens so that they could actually start to shift the culture within the prison from being a punitive place where people have to be punished for drug use or for mental health disturbance, to saying, actually, this person is suffering from a substance use disorder. This person is suffering from traumatic childhood. This person is suffering from post-traumatic stress disorder. This person is suffering from psychosis. So then how can we best kind of help that person to become whole, so that when they leave, they're become more chance of being reintegrated into society. So it's kind of like a therapeutic mindset, and it's a paradigm switch from the punitive corrective approaches to a more therapeutic model.
I think that's excellent. Yeah, yeah. I think it's something that we definitely need to pursue. And yeah, some of the Nordic countries and Germany, they have a very different approach to corrections, which is much more interested in the rehabilitation and reintegration of people, and a little less in the ongoing punishment of them, which would be, I think, really, really beneficial if we could get it up here. I noticed that the family doctors had a statement about solitary, which is good. I don't know if you had a chance to see it, or if you have any comments on that, but I think that's telling. Yeah.
So I mentioned at the beginning that I was involved in the Collaborating Centre for Prison Health and Education, but also I was involved in the College of Family Physicians. And so in that organization, advocating for a prison health program. So family physicians in Canada need to be competent in providing care to incarcerated people, and the College of Family Physicians should be involved in advocating for improved health for people who are incarcerated. So through the prison health program, we actually started writing position papers, and so I was involved in co-authoring this one on solitary confinement. It took us quite a few years, actually, because as the Prison Health Program Committee has representation from across Canada, so there's maybe 5 or 6 of us who have all worked in prisons. I think collectively we added up, we had 80 years of prison health, prison physician practice in this committee. And so our solitary confinement paper, as we were writing this position statement, it evolved over years. Like we started off saying, we should be saying, recommending no longer than 15 days, the same as Nelson Mandela. And then one person came to the committee one year and said, I think we should start over. We should scrap that, and we should actually talk about abolishing. And we went, what? So we actually started unpacking that, and that's basically where we landed. So what we're saying is that Canada should be working towards abolishing solitary confinement because it is bad for health. And so having that position statement means that family physicians across Canada who are working in corrections can actually then go to advocate for the patients that they're seeing that should not be in solitary confinement. Because health advocacy is now one of the competencies that we teach family physicians to have. It's one of the core competence skills. And so as health advocates, we're advocating for things that are detrimental to health. We're advocating to improve those. And so, yeah, it was a very powerful statement. It got a lot of media attention at the time that we released it. I think
Ruth, this has been terrific. There's obviously a wealth of things that could be done differently that we should actually try, that would make life easier for people who would otherwise be in isolated confinement and in ways now that are really devastating to them. I know that you have provided some advice in court cases about the implications of being in isolated confinement, and we'd love to share some of those with the audience. So if we could do that, that'd be great. And I would really want to thank you for spending the time with us to share your experiences and your advice.
Thank you. It's my honor and privilege. And thank you so much for all the work that you do, Catherine, and your organization.
Thank you, Ruth. Look forward to working with you again in the future. Take care.